Imaging Center.
Recording in progress.
And then returned to UVA, where he completed a 2-year advanced cardiovascular imaging fellowship and served as faculty in cardiology, radiology, and biomedical engineering for over 10 years at UVA. Prior to joining UCSF, he served as the section chief of cardiac imaging and director of echocardiography at Stanford. So we're very fortunate to have him join us here to head our echo and cardiac imaging section. Dr. Salerno's research involves the development and evaluation of novel MRI pulse sequences and techniques to improve the clinical utility of cardiac MRI imaging. And he holds multiple patents for novel MRI pulse sequences and has published extensively. And additionally, he is also an associate editor for JACC Cardiovascular Imaging. So we're very fortunate to have him give a talk today entitled Quantitative Cardiac MRI Stress Perfusion Imaging Applications in Ischemic Heart Disease and Heart Failure. Let's welcome Dr. Salerno. Thank you.
Thanks, Evelyn, for the very nice introduction. And it's really been great coming here to UCSF. Everybody's been super, super friendly and helpful. And since I'm giving the first one, that means it can only get better after this. So that's good. Okay, so here are some disclosures, research support from Siemens and GE Healthcare. So for this talk, in terms of my learning objectives, I want to first give you a general idea about MRI and explain some of the advantages of quantitative CMR stress perfusion imaging for evaluating patients with coronary artery disease, help you understand some of the clinical applications of quantitative stress CMR, looking also at microvascular disease, and then finally, we'll end talking a little bit about utility in heart failure and cardiomyopathies. So overall, we spend a lot of money evaluating coronary artery disease, but as what's now known for more than a decade, only about 41% of cardiac catheterizations demonstrate obstructive disease. If you want to look at more recent data, in the ischemia trial, 14% of patients with moderate to severe ischemia, this was primarily by SPECT, echo, and EKG, had non-obstructive CAD by coronary CTA. So I think in terms of evaluating ischemic heart disease, we want to have more efficient and effective risk stratification. We want to identify patients who will benefit from revascularization. We want to reduce doing invasive procedures in patients without obstructive disease, and finally be able to diagnose and prognose microvascular disease. So starting from the beginning here, cardiac MRI provides a comprehensive evaluation of the heart and coronary artery disease, including assessment of anatomy. It's really the gold standard for looking at cardiac function, really the only technique that can look at myocardial edema. The focus of this is going to be on myocardial perfusion for looking at obstructive coronary disease as well as microvascular disease, the gold standard for looking at focal fibrosis and scar. And again, it's one of the limited number of techniques that can really look at diffuse fibrosis. So really bringing a bunch of things to bear for evaluation of patients with coronary disease. So other advantages for cardiac MR, it provides a comprehensive heart evaluation, as I was just mentioning, no ionizing radiation. We can get higher spatial resolution than other nuclear techniques as well as PET. Short time for data acquisition, the studies can be done in under an hour. We don't have issues with attenuation similar to you have with nuclear imaging. And then there's a potential for absolute quantification of perfusion, which is close to clinical application at this point. So how does CMR compare to our other stress tests? This is a meta-analysis looking at studies using invasive FFR as the gold standard. And you can see that MR, PET, and CT really outperform, in this case, SPECT, and here SPECT and stress echo. So if you look at area under the curve for MRI and PET, those are the highest, followed by CT, and then further down, followed by SPECT. CT has a very high negative predictive value, similar but slightly better than MR and PET, but MR and PET have a better positive predictive value. Another way of thinking about the same thing is what range of pretest probability can you adequately rule in or rule out obstructive coronary disease. So here, when we're looking at what pretest range you can effectively rule out coronary disease, we see that CT, PET, and MR are pretty similar and really extend up to about 60 or so percent where you can still adequately rule out coronary disease. And similarly, on the other side, if you look compared to CT, this is one of the strengths of MR and PET, is that they're better at ruling in significant coronary disease. So what's some of the data that's going to underline some of the guideline changes that just happened recently? This is a CE mark trial, direct performance between CMR and SPECT using coronary angiography as the gold standard. CMR outperforms SPECT in terms of sensitivity and negative predictive value and accuracy. And really, area under the curve was higher, regardless of whether or not you're looking at single vessel disease, multi-vessel disease, left main coronary stenosis. And over the last couple of years, there's been a couple of trials that were pivotal trials for actually getting approval for one of the MRI contrast agents for CMR stress perfusion imaging. Here, the area under the curve was about 0.87. We were interested, this is now about a decade ago, people said, oh, it's great, cardiac MRI, but what does the prognostic data actually look like? And we know that having an abnormal myocardial perfusion study by MR is associated with a high odds ratio for cardiac death and non-fatal MI. And similar to the data for SPECT and PET, if you look at combined outcomes less than 1% per year with a negative stress MR. And then the last study that I really want to highlight, this is actually a strategy study in terms of revascularization, a multi-center comparative effectiveness study, almost 1,000 patients with angina, randomized to either having a CMR perfusion guided strategy, meaning they made the decision for revascularization based on the cardiac MRI, or made the decision for revascularization based on FFR. So in the study, fewer patients in the cardiac MRI group underwent revascularization, but there was really no difference in the primary outcome. And this data has been carried on past this point, and it remains no difference in the primary outcome. So kind of summarizing almost 2 decades worth of cardiac MRI research, in the 2021 chest pain guidelines, there's been a significant change. In the older guidelines, it said, oh, if the person can't exercise and if their EKG is uninterpretable, and a whole bunch of caveats for either really doing either MR or CT, recognizing the improved diagnostic performance, cardiac MRI has a class 1 indication for acute chest pain with no known coronary disease, acute chest pain with prior bypass surgery. Cardiac MRI has a unique class 1 indication, so patients with MINOCA or suspected myopericarditis, this is now a class 1 recommendation to get an MR in those patients. Also, acute chest pain with known CAD at 2A and acute chest pain with valvular heart disease. These other recommendations are all at the same level of recommendations as all of our other stress tests. So anybody that you would be thinking about, say a stress PET-in or a SPECT study, stress echo, those patients would be appropriate for MRI. And then also class 1 indications in stable chest pain with no known coronary disease or those with known obstructive coronary disease to understand functional significance. And then there's a number of 2A recommendations in ANOCA, stable chest pain with prior coronary disease, and stable chest pain with non-obstructive coronary disease. Okay, so that's kind of a little background on what the data is, kind of a quick idea of how we do the study. So typically we get some anatomic images and then we localize where the heart is. Since the heart lies doubly oblique in the chest, we want to get things oriented to the short and long axis of the heart. We do stress perfusion typically with either adenosine or regadenoson. We then inject a contrast agent, and then wherever the contrast agent goes is going to wind up getting bright in the image. Areas that are abnormal in terms of perfusion will remain dark. That usually takes us about 5 minutes or so. We get images of the heart function, and we do this either before or after the stress perfusion. We also have to wait about 10 minutes for a washout of contrast, so this is a good time for us to do additional imaging. We then, in some cases, do rest perfusion imaging, and then do late gadolinium enhancement. And our slots, we've basically built up our program from scratch at Stanford. We were doing the studies in an hour of the total slot for the patient's imaging, typically done in about 45 minutes. Okay, how do we do this, and what are these movies that I'm showing you here? So conceptually, what's going on is that we acquire images on most clinical sequences at the base, mid, and apical short axis views, and we acquire them with ECG gating. And each image is going to be, what these movies that you're seeing is basically one slice location at multiple different heartbeats, typically 50 or 60, while the contrast agent is passing through the circulation. And so what happens is that the gadolinium contrast agent shortens this T1 relaxation time of water. And so if we have a sequence that's basically, or a technique that's sensitive to this T1 shortening, then we can actually back out the gadolinium concentrations. So what actually happens is that when we inject it, you'll see a really large concentration in the LV cavity. The next thing that will light up will be normal segments that will have both a higher, faster upslope of the contrast and typically a higher peak than areas that are ischemic. Of note, the contrast agents are not intravascular, so they actually go into the interstitial space. And so this difference between the normal and the abnormal segments is actually transient. So here's a pretty old example, but pretty typical for 1.5T scanner doing perfusion imaging here. And here you can see first the right ventricle light up, then the left ventricle, and then you'll see a blush of the myocardium. And where the arrow sign is here, you can see a region that remains darker. When we look at rest imaging, it looks totally normal. And I'm going to kind of explain that we don't, in general, try to use rest imaging the same way. We look for scar using late gadolinium enhancement imaging, whereas on nuclear imaging, typically rest imaging is used as the best surrogate for looking at scar. Okay, so that's giving you a general idea of how we do regular perfusion imaging. So why would we be interested in quantitative perfusion? So there's really two really major areas that I think are important. One is we have an improved assessment of the extent of the burden of CAD. We know from older data that patients potentially benefit more with a greater extent of disease. The CT data from ischemia also shows us that people that have more anatomic disease also benefited more from revascularization. In left main, sometimes we can underestimate the severity of ischemia and also in three vessel disease. And the issue there is that your eye tends to always look at the area that looks like the worst defect, and therefore you don't always see the other perfusion defects. And then the second area is really assessment of microvascular dysfunction in patients with either ANOCA or ANOCA, as well as potentially some other applications in cardiomyopathies. So here are the two recommendations in the new chest pain guidelines, the 2021 chest pain guidelines. In obstructive CAD, it's useful to consider doing either quantification with either PET or stress CMR to improve diagnostic accuracy and enhance risk stratification. And then in patients presenting with persistent stable chest pain and no non-obstructive disease, stress CMR with the addition of myocardial blood flow measurements is helpful for improving the diagnosis as well as for estimating adverse outcomes. So this was work we did now about 14 years ago, where we looked at qualitative interpretation, first looking at perfusion reserve analysis. And what you can see here is that if you look at these blue bars, which is single vessel disease, visually you don't pick up that much of a difference between the two, whereas when you do quantitative analysis, you can really better tell the extent of ischemia. We also know that having abnormal blood flow, even in the absence of obstructive coronary disease, is bad. So if you look at diabetic patients who don't have any coronary disease but have a very abnormal flow reserve, their event rates are really the same as those with diabetes that have positive coronary artery disease. Whereas those that have a more normal coronary flow reserve, their event rates tend to be low. Oops. And really, this is a two-dimensional problem. We have both the coronary flow reserve, which is basically the ratio of the stress flow to the rest flow, and we have the myocardial blood flow, which here is shown on the flow reserve on the y-axis, and then on the x-axis, the actual stress flows. And we know that prognostically, those that have the really worst group is this low group, but also those that have abnormal flow reserve have worse adverse outcomes. with an intermediate if you have just an abnormal myocardial blood flow compared to baseline. So again, just going on this recommendation in coronary disease, how do we quantify stress perfusion? So we kind of do the same kind of imaging, and then the only trick is we add another little acquisition in order to get the signal in the blood pool that has much higher doses of contrast, and the LV cavity is larger, so we can actually make a lower resolution image and one that's more sensitive to higher concentrations of gadolinium. So what we do then is we have an image of the blood pool that lets us get the concentrations in the cavity, and then we have this other high resolution image where we can get the concentrations on a pixel-wise basis within the myocardium. And then we do a certain type of fitting called deconvolution. I'm not going to get into technically how it's done, but suffice to say, if we know this initial amplitude of this impulse response, then that is the flow per unit volume. So we can directly quantify myocardial perfusion, similar to what's done with PET imaging. And in order to really make this work in practice, there's a number of different steps. After the data acquisition, we have to do some pre-processing, converting to these gadolinium contrast units, doing the quantitative analysis, and then doing some type of display. So here's an example from some work that with some techniques that we had developed. Again, this is from quite a while ago, but it's a really nice example here of a perfusion abnormality in the anterior wall and in the septum. And actually, you can appreciate having high resolution. We can actually see the transmural differences across the wall. And here is the quantification in this case. What we can see is that the flow in this area is quite low. Normal flow would be above 2, and this is like 0.4. And if you look at rest, in this particular case, it's actually higher at stress than it is at rest. So this is consistent with SEAL. Of note, the other territories all have fairly low stress perfusion values, and in this case, pretty high resting flow. So there's going to be abnormalities in flow reserve that are more global in addition to this regional abnormality. And here are the flow reserve numbers, all really less than 2, only bordering 2 a little bit in the circ territory. And then when you look at this person's coroners, they're basically horrible as you'd expect, like tandem 99% subtotal occlusion of the LAD, moderate disease in the circ and right. And you can see that in the gradient also if you look at the perfusion values. So other groups have been working on this as well in terms of doing fully automated quantitative perfusion. The test performance, again, really in the mid-80s with accuracies in the mid-80s to 90s. And a recent advance has really been putting some of these things online so that a perfusion map will spit out on the scanner right after you're done doing this. This is work from Peter Kellman working along with Siemens, and we've used their technique also in some studies. So in this study, they used FFR as the gold standard, 50 patients, 15 volunteers, and a cath. In addition to doing FFR, they did CFR and index of myocardial resistance, which gives us an idea for microvascular disease. And what they found was high diagnostic accuracy for stress blood flow. For obstructive disease in general, stress blood flow a lot of times beats myocardial perfusion reserve for obstructive disease, which you can see here, but again, both having high test performance. And here are some examples from those images. Here the resolution is a little bit lower, but still enough for us to be able to tell differences between the endocardium and the epicardium. And then some recent work just published in JACC Imaging recently. This is a registry that we were part of. This is data from about 100 cases using kind of all comers, a really suboptimal real world kind of experience. And what this study showed is that actually, and this is one of the first studies to show that quantitative analysis actually outperformed the expert readers. A lot of the data suggests that it's actually pretty similar. But what it does also tell you in general is that if you take these techniques and apply them more broadly, you don't necessarily have the world experts as the people who are the readers, and the quantitative analysis can kind of up people's game. Okay, so in terms of other research that we were interested in, as I showed you most of these images, there's only like 3 slices, and you can be like, well, PET, we get the entire ventricle. So, we've been very interested in trying to do high resolution whole heart perfusion imaging. Here's a study that we did in 25 subjects, 10 controls, using invasive angiography as the gold standard. And here we can see on these techniques that we can get very high resolution and really cover the entire heart from apex to base. Typically, it takes about 6 slices to get full heart coverage here with about 8 millimeter thick slices. And so here, your first thing your eye picks up is that there's obviously a perfusion abnormality in the inferior wall. If you look more subtly, you'll see that there's actually abnormal perfusion with some gradient in the other territories as well. Oops. And then when we go and quantify it, sure, the RCA is totaled, so that's why it's the worst, but there's actually also moderate disease in the circ, as well as some moderate disease in the LAD. And when we look at the quantification here, again, the worst stress flows are in the inferior wall, but they're abnormal also in the circ and sort of borderline in the LAD territory, which would go along with the disease that I just showed you there. The circ looked a little bit worse than the LAD. Diagnostic performance, again, sensitivities in the mid-80s, accuracy in the mid-80s, with either visual analysis of these images or by looking at ischemic quantification. And as one might expect, that if you look at global values, you see a progression in the abnormalities as you move from either single vessel disease to multi-vessel disease. And now one problem really starts becoming is that when you really have very high resolution, we need to start thinking of better ways of just doing just the 16 segment model, or just doing flows for each of the different territories, because you could certainly have something where you have a mid or distal LAD, and when you have the whole coverage, we can start looking more specifically at those things. Other groups have looked at this also, and again, showing in multi-vessel disease, ischemic burden using mapping is higher than what you tend to see with visual analysis. And it was, in this case again, was improved in terms of the performance in multi-vessel disease and 3-vessel disease. How about prognostic utility? Now, this is a 2-center study, 1,000 patients. Again, as you'd expect, showing that abnormal flow reserve is associated with worse outcomes, whether that's MACE or cardiac death. Okay, another thing we're interested in addition of trying to get this whole heart coverage is really to get higher resolution. So to be able to really look at transmural differences in perfusion. And why are we interested in that? We know the endocardium is more sensitive to reductions in perfusion reserve as compared to the epicardium. We also know that when you look at this gradient across perfusion, you can actually see this gradient if you actually have higher spatial resolution. So a lot of times in 3-vessel disease, we'll actually see that you can visually, it doesn't just look like a normal study like you might see in a SPECT study or where it's very difficult to tell. We'll usually see a gradient from endocardium to epicardium across the different territories. And so we were interested in looking at transmural differences and seeing if that could help us look at the differences between microvascular disease from obstructive disease. And so here are some results from these very high resolution techniques. Here in a patient, you can see a perfusion abnormality, primarily in the LAD territory going from apex to base, and we can nicely see transmural differences in the perfusion. And here are the resting images. And then again, here when we can do pixel-wise quantification, as well as put these in bullseye plots, and here, marked abnormalities in the LAD territory. And in this particular case, the patient where we look for to try to figure out whether or not it's ischemia versus an infarct, you can actually pick up that there's a very, very subtle myocardial infarction here in the anteroseptum. You probably wouldn't see with techniques other than MR. And here you can see he's got a subtotal occlusion of his LAD. Okay, that's what I want to say about obstructive coronary disease. We know that we have good performance. There's a lot of interest in using quantification, similar to in the PET world as well, of improving this. How about microvascular disease, and why do we care about it? So there's really a growing recognition that microvascular dysfunction can cause cardiac angina in the absence of obstructive CAD. There's a large literature in the PET literature, but now also in the MR literature, showing that abnormal flow reserve is associated with adverse outcomes. And really, these patients can have significant comorbidities and limitations to their life. And a lot of times they'll go to the cath lab. Somebody will do an angiogram and say, you're all good. And then they still have pain. So I think this is an important growing area, particularly among certain populations. Excuse me. And in the chest pain guidelines, as I mentioned, this 2A recommendation for improving diagnosis of coronary microvascular dysfunction. And so when we think about microvascular dysfunction, by cath, we're usually just assessing the epicardial vessels, but there's really a huge amount of vessels downstream. And pathophysiologically, there's a number of components. One is impaired vasodilation, which can be endothelium dependent or endothelium independent, as well as inappropriate vasoconstriction. And really, this is a whole entire lecture of itself. However, of note that basically this is very present in about 50% of the patients that were undergoing PET in this large registry from the Brigham, and associated with adverse outcomes and largely independent of gender. So we know there's a lot of ways invasively of looking at assessing coronary microvascular dysfunction. We can do coronary flow reserve, where we can measure the hyperemic flow at Doppler over the resting flow. That ratio is coronary flow reserve. The either MRI or PET equivalent would be the myocardial perfusion reserve, which is the hyperemic perfusion divided by the resting perfusion. Another way of getting at the coronary flow reserve is that we can actually measure the blood flow in the coronary sinus and do that at stress and at rest, and that difference can give us the coronary flow reserve. Invasively, other things that you can do, you can look at the index of microvascular resistance. We don't have a way of doing this, so this is trying to treat this in a very simplistic way as like a V equals IR, and trying to get this resistance. In the cath lab, you can look at, when we give adenosine, that's endothelially independent. There are tests to look at endothelially dependent mechanisms. The mechanism of doing this in the cath lab is looking at response to acetylcholine. In normal vessels, it should cause vasodilation. And in those that have endothelial dysfunction, you'll get vasoconstriction. On MR, that's actually the IMR. We don't really have an equivalent. And people have done stuff to look at endothelially dependent, such as doing a cold pressor test where you put somebody's hand in ice water, but these aren't really done typically. It's not that easy to do. So here's a case, was in one of our research studies. 57-year-old female underwent coronary angiography for stable chest pain, showed no significant coronary disease. And what we see here, her stress images are on the top and rest images are on the bottom. On the stress images, we can see a slight reduction globally in the subendocardium, particularly on this middle slice. And when we quantify it, we can actually see it even easier there. Here, global perfusion was around 2.1, and resting perfusion was around 1, and a flow reserve was right around 2, suggesting that this patient has microvascular disease. And we did a study looking at about 50 patients who went to the cath lab and 20 age-matched controls. These patients had to be either women, diabetics, or have metabolic disease. And just among that cohort of non-obstructive disease, we were able to show that there's both abnormalities in myocardial perfusion reserve as well as stress perfusion, whereas all of the other parameters were really pretty similar with these patients. So again, here's an example of that inline stress perfusion mapping, which is probably about a year from being clinically available, although we have it available. We will have it available when we get our stress program back up and running, hopefully in the next month or two here. Here you can see this variation where it's lower in the endocardium than it is in the epicardium, kind of a classic pattern for microvascular disease. However, the caution is that if you just look at this pattern, the visual assessment is really not that accurate, because we also have cases where it's very global and you can't really appreciate that much of a gradient. And adding the quantitative assessment significantly improves accuracy, whether you look at the endocardium or the global myocardial perfusion reserve. So where does this fit into the guidelines? So again, this is from the 2021 chest pain guidelines. They're sort of an invasive route, 2A recommendation, looking at assessing CFR, IMR, as well as potentially doing acetylcholine testing. I know we're working on this in our lab currently. I'm not sure if are we up and doing the acetylcholine testing for microvascular disease? Yeah. So that's becoming, there's more places that are doing this now. And then the other route would be doing stress PET or MR with myocardial blood flow. There's a 2B recommendation for doing this with stress echo, but it's pretty difficult doing flow in the left main to look for global dysfunction. So if they see abnormalities here, then the thought would be to either treat them or potentially, if they don't have, if they have normal blood flow with evidence of ischemia, then moving on to cath to look for obstructive disease. And then finally, this group of reduced blood flow, where we don't have an abnormality, where you have a high suspicion, some of those patients will need to go on to invasive assessment. I wanted to throw this in for Roselle and a couple of other people who are interested in TED and others who are interested in cardiomyopathy. So actually, they've done a lot of the work in PET, looking at these, looking at flow in the heart. Here is quantitative stress perfusion imaging. This is in 100 patients with HCM and 30 controls. And what we can see is that the stress myocardial blood flows are lower in the blood stress flows, as well as the NPR are lower in hypertrophic cardiomyopathy. Here we can, again, really see, particularly in hypertrophic cardiomyopathy, this endocardial to epicardial gradient that you get from hypertrophic cardiomyopathy. Whoops. And then of note, other really interesting work looking at quantitative perfusion in apical hypertrophic cardiomyopathy. This group, in looking at 100 patients, 68 with overt hypertrophy, as well as some that had this sort of phenotype. When you look at them, many of them had an NPR less than 1, meaning that there's actually worse flow at stress than rest. And universally, in apical hypertrophic cardiomyopathy, they have abnormal perfusion at the apex. And so this was a pretty cool figure. They actually put all of the images to show that not just their best case, and you can really see that in all of these apical hypertrophic cardiomyopathy cases, we can see abnormalities. And so I think some of the areas that will be really interesting, we'll be looking at new therapies like mavacamten and other things. How do these modulate myocardial blood flow? Can we use this to try to help us in difficult phenotypes? If somebody has a ventricle that looks sort of potentially hypertrophic cardiomyopathy, but not meeting all the criteria, can perfusion or abnormal flow reserve be something that helps us as well? So here was a case that we had referred. It was actually just referred for stress. So one implication of this whole thing about all of these defects in hypertrophic cardiomyopathy is that sometimes it can be challenging to use vasodilator stress imaging in these patients with hypertrophic cardiomyopathy, because very frequently they'll have abnormalities. So here we can see the wall motion. As we move out to the apex here, we can see that there's complete cavity obliteration. At the very apical segments, we can see that there's actually an apical aneurysm. Seen a little bit better here. This apical aneurysm here, as well as this marked apical hypertrophy. And then here are the stress images visually on the top, and then the quantification on the bottom. Actually, this middle image is acquired during systole, so you can't even see the cavity, but you can see the abnormalities in the flow. And then at the apex here, you can see this kind of classic endocardial to epicardial gradient in this apical hypertrophy. For my other heart failure friends that hopefully will maybe do some stuff in cardiac amyloidosis, throwing this one in here as well. We know that patients that have amyloid have severely reduced myocardial blood flow an NPR that's really similar to patients with multivessel coronary artery disease. Again, is this an early finding? Is it a late finding? Are there interesting things to do in other non-ischemic myopathies? Okay, last topic that I want to talk about in this lecture is heart failure preserved EF, and then we'll take some questions. As we know, highly prevalent, about half of the cases, complex pathophysiology, including impaired relaxation, increased fibrosis, and stiffening of the ventricle. We also know that there's roles of inflammation, microvascular dysfunction, and really still limited therapeutic options. And I would make the argument that CMR is really the ideal technique for looking at heart failure preserved EF. We're able to get out images of the function, LV mass, volumes. We can do strain imaging, also to get more detailed information about the cardiac function. We can do late gadolinium enhancement imaging to look for focal fibrosis. We can do T1 mapping, pre and post contrast to look for diffuse fibrosis, which we know are all related to the pathophysiology. And then we can do stress perfusion imaging and looking at microvascular disease. So here's a case from a study that we did. I'll show you some of the actual details on the next one. Stress images are on the top, rest images are on the bottom. And what you'll see in a lot of these HFpEF patients is maybe there's a subtle endo to epi gradient, but it's very, very subtle, and not that you would pick it up. However, when we do the quantification in this particular case, we can see that these stress flows were significantly reduced below 2. Rest flows were pretty normal in this case, so suggesting that there's a component of microvascular disease. And so in this study, we had about 20 HFpEF patients, 15 age-matched controls, which really were free of cardiac disease. And the main findings that we saw, the extracellular volume fraction, which gives us an idea of the amount of diffuse fibrosis, is higher in HFpEF than it is in the normal controls. This has been shown by us and others. One of the things that's interesting is this extracellular volume fraction is actually a ratio of the intracellular component and the extracellular component. So the reason we don't see marked increases in this extracellular volume fraction is that they tend to get cellular hypertrophy, which is going to tend to drive the ECV down, as well as the increase in the interstitial space. So those two things are actually competing against each other a little bit. However, when we look at the global myocardial perfusion reserve, was really normal in these controls, markedly abnormal in these patients. All of the other parameters of the morphology, the LV mass was actually similar. EFs were completely similar. And these patients, just for what it's worth, if you look at their VO2 max, you can see that these HFpEF patients were at a marked decrease in their functional capacity. So patients that visually you wouldn't really pick up anything, where this ECV and global perfusion reserve give us novel information. And then in our study, we saw a relationship between myocardial perfusion reserve. So the higher the myocardial perfusion reserve was associated with lower extracellular volume, looking at sort of the relationship as the disease progresses between fibrosis and abnormalities in perfusion. There's a few other studies that have looked at this. This was a study looking at women with obesity, heart failure, preserved EF. And in this study, they found that this endo to epi ratio, so using this higher resolution and starting to use that, correlated with diastolic dysfunction by echo, fairly small study. And then probably the largest group here, about 150 patients with HFpEF and 43 age-matched controls. The NPR they found lower in the HFpEF as compared to controls, with a significant number of patients of the HFpEF population having a flow reserve less than 2. In their study, they didn't see much of a correlation between the flow reserve and the fibrosis, which I think still requires further study. So I want to kind of leave off there and leave some time here for questions. Summary of what we've talked about. First, talked about some of the performance for just general stress perfusion. MR is really a state-of-the-art technique. Better looking at scar than we do with our other nuclear techniques. Very high spatial resolution and accuracy, and can be combined with all this other information that we can get from MR. Quantitation adds another part to this, where we know that this can improve both our diagnostic and prognostic utility. CMR is showing insights in microvascular disease and ANOCA. This is an area that's ripe for thinking about novel therapeutics. How do novel therapeutics change the perfusion in the heart? We think that high resolution imaging, as well as getting whole heart coverage, will help us really differentiate obstructive disease from microvascular disease non-invasively, which has been challenging for techniques such as PET. And finally, we think that quantitative perfusion imaging can provide new insights in heart failure preserved EF, as well as really trying to visit other cardiomyopathies that previously really didn't have a lot of therapies or really interest in really trying to distinguish very carefully between these myopathies. And now we know that we have different treatments, and we know the disease. You can't just have a global garbage dumpster of non-ischemic myopathy. We now know that these are different etiologies. And then finally, I want to give some acknowledgments to our current lab. All of my current lab came with me from Stanford, including Katie, who's our study coordinator, who's actually in the back. Had a number of imaging fellows working with us at the time in Stanford. My former graduate students, my imaging fellows, there's about 30 of them, but these are the ones that have primarily worked on perfusion. Industry collaborators. And then I want to really thank also my new cardiology and radiology colleagues. I think we have a good potential to really have an incredible program and really bring up the level of cardiovascular imaging at UCSF. If you have ideas or things that you think could be better, please bring them up to me. And then I'm going to give a shout out to my wife, because I realized recently I'm not going to win a Nobel Prize. So I thought this would be a good time to say I really appreciate her. She's actually working here in cardiology now as well, and for putting up with me for all this time that I'm working with all you guys. So thank you very much.
Thank you, Dr. Salerno, for a great talk. So now we'll open up. All right, so now we'll open it up to questions, comments. For people on Zoom, feel free to raise your hand and unmute yourself. If you're not at a good place to speak, then you can also leave comments in the chat. So we'll start with Arthi.
I was just curious. Thanks for the talk.
Yeah.
I was curious about myocardial perfusion imaging in anomalous coronaries.
So I think this is it's an interesting question, and it's come up like a number of times recently. So I think the questions are, if you're doing a vasodilator stress, do you really get the same increase in contractility, increase in distension of the pulmonary arteries and other things that you get with exercise? And the answer is probably no, but it hasn't been looked at that carefully. The other choice, which people have done also in the nuclear world, would be doing it with dobutamine. With dobutamine, you probably get an increase, some more increase in contractility. But then again, I think really what you probably really want to know is what's going to happen to these guys when they're exercising, and that's when they're having sudden death. And so there, personally, I think vasodilator stress would not be my real choice for those patients, although I think there's some growing interest in this area.
Great talk, Mike. I was just wondering if you could speak a little bit to what you think some of the barriers are to centers adopting CMR stress perfusion. There's been an explosion in the use of cardiac MRI in different centers, but what is it that you think limits or has been limiting places from doing this more often, including here?
Yeah, no, I think that's a great question. So I would say number one issue at most places is basically access. So being able to access the scanners and being able to have the infrastructure to basically do stress studies. So I think once you overcome those two barriers, I think it could be more widely used. Other issues that I think we have, which I think is starting to change, is really having enough people that are really trained and that are basically champions of it. A lot of times it's not necessarily under our control how the scanners being. So when we were at Stanford, took a long time to get this way, but we also ultimately got up to a day that we had the whole day. And then I think the other issue is just that, similar, if your throughput is around an hour, then there's a limit to how many. But I think that there are also things that faster. The main question is, will our coronary artery not interested? You don't really rest. So I think there's both an opportunity to kind of increase, but the biggest access in my mind is still having access to technology, controlling some part of the schedules that do these studies. In reality, going from an MRI to a stress MRI is essentially 5 time. It's just the time to do regular. And so it's actually not that much harder to do a stress MRI than regular. So I think that's probably some. We're hoping to get the program first up and going at China Basin, where we have our radiology colleagues, the nursing piece, the other piece, and then probably once we get that up and running, although it's not the most optimal, we have scanners to do it. And then the other thing is referral pattern, right? So people need to know about it and they need to be thinking about it. I think the new chest pain guidelines are basically putting us in where instead of there being 50 caveats for why those caveats are largely actually based on real data of how the test perform rather than some other last thing, which I've long answer question, is I think that the quantification don't have either.
Thank you again, Dr. Salerno. I was curious, speaking of caveats, we have so many patients with advanced CKD and ESRD and how the latest generation of gadolinium-containing agents that we use, how do we think about NSF?
So the answer on that, there's a clinical guidance from the ACR, which essentially says, even in people that have the biggest issue where you probably don't want to do it is it has the highest risk of having it. But basically, most of the issues with NSF were for 2006, mostly cases where we gave and they were older agents, and their agents they actually bind the the CR guidance actually says don't even. I think it's a little bit personally, but we've done personally do far less than 30 hours.
We have a lot of questions on Zoom as well. Maybe we'll do a couple questions from Zoom, and I know Pooja has a question here as well. So we'll start with Davis. So Dave asking, does quantitative CMR perfusion parameters in epicardial and microvascular disease improve with medical therapy?
This is a very good question. There, actually can do it.
All right, and if you can get a little bit closer to the mic, keep on Zoom.
So the answer for the MR is just there's not a lot of studies looking at it. This is actually something we're interested in, probably trying to look at mavacamten and some of the non-obstructive cases, right? Can they potentially have improvement? Do you get improvements in, what other medicines? What happens? We were doing a study before I left UVA that now somebody subsequently has taken over of looking at like SGLT2 inhibitors. What happens with GLP-1 inhibitors? Are these things we can study and basically see what the impact is? We know things like beta blockers and other medicines modulate the perfusion numbers that you get with therapy. And in the spec literature, it's been shown that if you're on beta blockers, you have less obvious perfusion defects, which potentially means that you're not having as much abnormal perfusion. But it also can be confounded when you're just looking at it with spec because you're just looking at relative differences. So there's not a lot of data with MR, some data with PET, but I think it's an important area.
And there, a couple of people asked about limitations in the arrhythmias from Dr. Goldschlager and Ed Gerstenfeld. But Dr. Goldschlager had her hands raised, so have her unmute and ask
Thank you.
any more elaborate.
Thank you very much for this. I do both. I put it in chat and hand raised. That way I get a double shot at asking the question. My own question with regard to rhythms is, are there specific issues with this technology in paced patients?
So the answer there is more related to effects from the pacer ICD. And people have looked at this. You have to do some things to make there's some technical aspects of things that you need to modify to get the saturation pulses to work well in the setting of, it's usually the metal from the device. And it's usually only ICD. So there are places that do. We are currently not doing it and won't foreseeably do it in the very near future. But you can do studies in patients with pacemakers, do stress perfusion in patients with pacemakers and ICDs. Pacemakers usually don't cause much of an artifact. The guys that do this in patients with ICDs, usually it will be one of the things like, if you have a lot of artifact, then they won't do the stress perfusion imaging. But it's certainly possible to do it in patients that have devices in the right setting. I think that's one of the examples of like, can we do it versus should we do it? I think on those patients, I'd probably just get a PET, at least in the situation now. Another really interesting area for this is low field. So we have a low field scanner here, so much less susceptible to metal artifacts, an area that we'll be interested in kind of exploring to see, can you do perfusion and other things on these machines. And then the one over arrhythmias, we can, with a lot of these techniques, we can image 3 slices up to about 120 beats per minute. The image quality is a little bit more challenging with patients who have like very abnormal rates in atrial fibrillation, but the test performance is actually still reasonable. People have looked at that before, at least for visual analysis. Quantification is harder because you have to do, if the heart changes, where you are in the cardiac cycle, the size of it will change on the different phases. So it puts a little bit higher burden on motion correction.
Does a paced patient interfere with accuracy of interpretation? In other words, is there artifact in your results in patients who are paced?
Yeah, so kind of as I was saying, there's a limited data in looking at paced patients and doing stress perfusion imaging in them. Pacemakers, for the most part, don't cause much artifacts. So we can actually do pacemaker patients using pretty standard techniques. The biggest issue is just where is the can relative to their heart. So if the device, based on where it is near their heart, you'll get some abnormalities in the signal intensity. And if it basically blows out the signal over the anterior wall, then why would you bother doing a stress MR and not be able to look at the LAD territory? So I don't think it's other than the same caveats of any other thing of doing a vasodilator in a paced patient is really no different with MR.
Thank you.
Other than you need to logistically be in a setting where you can actually do stress on patients that have devices, which we currently, don't have in the short run here.
All right, few more questions. So Dr. Russell Chen is wondering, how does CTA FFR fit into your algorithm for evaluation of CAD or row width imaging?
Yeah, so I think this is sort of again, maybe I'll come in the next time we get to do grand rounds, I'll do it on CT. So I'm not like, this isn't an MR versus CT. I think both of the techniques are very, very useful. And in fact, I think the future really for cardiovascular imaging in coronary disease is both CT and MR. So I think more broadly, let me say the patients with CT, low risk patients that you want to be able to see whether or not they have plaque in their arteries and how that changes management, cases where you really need to rely on the negative predictive value. I think those are the sweet spot for CT. The CT FFR, I think in intermediate disease, it's helpful. It doesn't bail you out if you have a crappy quality images. It could actually give you false negatives or positives. And in markedly calcified disease, we've published on the fact that it doesn't perform all that well because in the end, you're doing computational fluid dynamics. And if you don't actually know the boundary conditions, if you don't know where the actual wall is, you can't do this that accurately. On MR, I think the sweet spot for MR is guys that need an ischemic evaluation who you're also not sure if they could be a non-ischemic myopathy. Some of the new onset heart failure patients that we know have known coronary disease, where the question is how much is scar, how much is ischemia. I think those are kind of the spots where I think MR, really shines. I mean, you could do it across anybody. You could do somebody who's basically, very low risk, and it's a low risk procedure. But really, I think the sweet spot is sort of the more complicated patients.
And how does the cost compare to stress echo?
I love this question. So this is my favorite. The answer is that people don't usually have this right. So I can tell you that if you look at Medicare reimbursement, I think the Medicare reimbursement for a stress echo and a stress MR is actually the same, which means they cost the same, which is good and bad. CT is lower, is actually the lowest out of everything. It's only pays like $280 on Medicaid. Now, nuclear SPECT is $1,200, and a PET is $1,400, and stress echo and MR reimburses that around $800. So actually, the study that you don't think twice ever about, is a SPECT study too expensive for me to get one in my patient, is actually going to cost your patient and actually the system more than getting an MR. That also is true if you look at commercial payers. When we looked at this analysis at Stanford to do a PET, if you say one is an MR, PET was 2.4 times the cost. A CT was 0.8 times the cost. A nuclear was about 1.4 times the cost, and a stress echo was about half the cost. So it depends on what your payer mix is. If your mix is primarily Medicare, it's really not that much of a delta. So I don't think, compared to everything else that we do to people, that this is one where I would decide, no, I'm not going to get a cardiac MRI because it's too expensive. It fits in with the other tests, and actually nuclear tests are actually more expensive.
Great, good to know. Well, thanks again, Dr. Salerno, and thank you everyone for joining for Grand Rounds today. Thank you.